Welcome to Somerset Medical Center's Health Talk. I'm Dr. John Bucek, Director of Somerset Medical Center's Family Medicine Residency Program. Lung cancer is the leading cause of cancer-related deaths in the United States. Because it is asymptomatic in its early stages, most cases of lung cancer are not identified until they are in an advanced state, when treatment options are limited. New studies have shown the benefits of annual CT screenings for people at high risk for lung cancer. Based on this new research, Somerset Medical Center recently formed a lung screening program to promote the early detection of the disease. Joining us today to talk more about lung cancer screenings are Dr. Steven Einreinhofer, a pulmonologist with Somerset Medical Center's Steeplechase Cancer Center, and Jill Steck, a registered nurse who is the lung cancer patient navigator at Somerset Medical Center's Steeplechase Cancer Center. Good afternoon. Welcome.
Thank you.
Good afternoon.
I guess we could start by learning more about the studies that, show that screening for lung cancer might actually be beneficial to patients. Can you tell us a little bit about that?
Sure. There was a recent trial that was published in the New England Journal of Medicine that was supported by the National Cancer Institute. And it looked at little over 53,000 patients over a several-year period of time. And what they did was they wanted to compare low-dose screening CAT scans with conventional chest radiograph or digital radiographs to see if there was a benefit in doing the screening CAT scans. They separated these patients into two groups. One underwent the conventional chest x-rays on a yearly basis for 3 sequential years, and then the second group underwent low-dose screening CAT scans for the same time period, at baseline year 1 and year 2. Then they were followed for an average of an additional 3.5 years post-screening to determine if they had developed lung cancer.
And so there was the benefit?
There was a market benefit. The trial was actually terminated early due to the fact that they found a 20% reduction in mortality rates in the individuals that were in the screening CAT scan group as compared to the ones in the conventional chest x-ray group.
So just to repeat for us and clarify, which patients seem like they might get benefit if they participate in this kind of screening?
So there was a list of inclusion and exclusion criteria for the trial. The main ones were age, where individuals were between the ages of 50 and 74. They needed to have a 30 pack year smoking history. And a pack year is packs of cigarettes per day times years of smoking. For example, 1 pack a day for 30 years is 30 pack years. A half a pack a day for 60 years is 30 pack years, and 2 packs a day for 15 years is 30 pack years. Those are equivalent amounts of smoking history. And then the third was either to be an active smoker or to have quit within 15 years to be enrolled in the trial.
So now that we have a group of patients that might benefit, we want to try to figure out a way to get them to do this screening. Do you want to tell us a little bit about the lung cancer screening program at Somerset Medical Center?
Well, we're going to be starting the screening. Our goal really is to try for September. And we were going to open it up to patients who meet the criteria that Steve just mentioned. And basically, really, we want them to go see their primary medical doctors and determine if they are eligible for this. And again, Steve mentioned it, we're looking at 50 to 74 with a significant smoking history. And also patients that have had secondhand exposure, or also exposures to, asbestos and things like that, which weren't really included specifically in the study. But those are also patients that they're at risk. And we would like to help them determine if there's some situation that we can help them prevent any problems or detection in the future.
Now, patients might hear about this. Are you going to also educate physicians? Because if this is a new study finding, physicians might not be aware of this yet. I mean, how are we going to help the primary care doctors understand also?
Well, I think part of getting the program up and running at Somerset Medical Center will be an educational piece in which a team will probably go out to some of the individual primary care and internal medicine doctors in the area, inform them of the program, the criteria, and the benefits to their patient population.
So if a patient realizes they're in the screening group, the group that would benefit, and they want to have this happen, do they need a prescription from their physician? Can they themselves go sign up? How do they get into the program?
They do need a prescription. We would prefer if they would obtain that from their primary care doctor, so they can discuss why they feel they need screening and to go over the pros and cons of screening.
Now, if there's studies that show that it's definitely a benefit to some patients, are insurance companies going to pay for these kind of CT scans?
Unfortunately, right now, most insurance companies do not cover screening CAT scans. They cover CAT scans which are related to symptoms, but in the asymptomatic individual, despite having risk factors, right now it's an out-of-pocket expense. I suppose in the next few years, we'll see some changes in some of the major insurance carriers, which will perhaps cover the screening CAT scans, just like they cover screening mammographies and colonoscopies at this point.
Now, if you're one of the patients who would benefit and you do what's recommended, you're going to have this how often? Once a year?
Initially, it'll be a 3-year program where each year for 3 years, you'll undergo a screening CAT scan. Now, obviously, if in that first screening CAT scan something is found, an abnormality is detected, depending upon that specifics of that abnormality would kind of dictate whether or not you stay in the screening program or whether you go into a different, more aggressive investigational treatment arm.
So if I get 3 CAT scans and then I need more, isn't that a lot of radiation? Are some patients going to come to you with concerns about radiation? What are you going to tell them? Is it really a risk?
Yeah, I think any exposure to radiation is a risk, and I think you have to weigh those risks. And if you have been smoking for 30 years, that's a risk too. So yes, that is one of the discussions about the study, and that was taken into consideration, and overall they determined that they really felt the risks of radiation exposure were far outweighed by the significant increase in survivorship for patients who we do identify lung cancer early. Mm-hmm. Because as we all know, once lung cancer is detected at late stages, survivorship isn't very good. So the earlier we can detect it, the better off all of the patients are going to be.
Correct. And if I may add, I think that's the key point, because lung cancer tends to be asymptomatic until it is advanced. So if you're waiting for someone to develop symptoms of lung cancer, it's usually too late to treat surgically, and we're not talking about curative procedures at that point. We're talking about managing the individual and trying to lessen their morbidity. The purpose of the screening criteria, limiting to those individuals of a certain age, certain smoking history, is because there is risk with radiation exposure. And the fact that we have low-dose screening CAT scans available now help lower that risk of potential risk for cumulative radiation exposure in those high-risk individuals.
In the unfortunate circumstance where somebody's found to have an abnormality on one of their screening CAT scans, you know, who takes care of them? What happens? What are they facing?
Well, again, the specifics of as far as what the actual abnormality is kind of dictates what happens next. The individuals who have been screened through the national screening trial had pulmonary abnormalities detected, and then they had non-pulmonary abnormalities detected. So for the purpose of this talk, the pulmonary abnormalities usually involved a pulmonary nodule or a spot on the lung. Now, depending upon the size, kind of dictates how that patient would receive follow-up. Certain sizes would just need to be followed through the 3-year process to see if there's any change. If there's no change at the end of that 3-year process, these were deemed to be benign findings and no further investigation was warranted. If there was any growth or the initial nodule was of a certain size, then a more aggressive approach would be required.
So a good number of people who had something on their CAT scan had more CAT scans, but not necessarily anything else. It was found to be not a concern later on?
Correct.
Okay.
In fact, the study, the number of individuals who underwent invasive diagnostic procedures was actually fairly small.
So what is invasive diagnostic procedures? Is that a biopsy? Is that a surgery? What is that?
There's basically 3 ways of performing a biopsy on someone who has a suspicious pulmonary finding. One way is a CAT scan guided needle biopsy, in which under CAT scan guidance the appropriate area is marked, and then the individual has a needle after the skin is anesthetized and placed into that nodule, and cell samples are obtained. The second way is a test called a bronchoscopy, in which a flexible fiber optic scope is placed down into the airway and samples and biopsies are obtained from the inside of the lungs. And the third way is surgical biopsy, which in small nodules is usually not only the biopsy and try to find out what's going on, but it's actually the treatment of choice to have it removed.
So an extreme example would be to go to sleep, have a scope put in your chest, find the nodule, and take it out.
Exactly.
Okay. Jill, help us understand a little bit about what the role of the patient navigator is. If a person finds that they have a prescription from their physician, the physician thinks they're a good candidate for this, what happens? What do they go through?
Well, right now, they'll be able to call the lung screening center, and we will be able to schedule them for a CT scan. Once they have their CT scan, we will take those reports, forward them on to their primary care physicians, and depending, again, like Steve said, what they find is really going to determine how they're followed up. Obviously, any of these patients who come in and they're currently smoking, we really want to, the primary goal is not only to help prevent lung cancer and to treat it early, but to get patients into a smoking cessation program. And at Somerset, we have a great program. Dr. Coatson heads up that smoking cessation. So that's one of the primary goals, not only to prevent people from even starting to smoke, because as we know, smoking is one of the #1 causes of lung cancer. So once they come in, and the role of the lung navigator is really, there's multiple roles. It's really individualized assistance in getting to the doctors that they need to see. Or once they're here at the hospital for surgery, a VAT surgery, which is a video-assisted thoracic surgery, which, as Steve mentioned, was the third option, which we go in. We have 2 very good thoracic surgeons, Dr. Cacavalli and Dr. Bocage, and I see all of those patients. And I help take care of them in the hospital. I work very closely with the nursing staff and the social workers in case management, and explain if they have questions about clinical trials, and really to help individualize their care at the hospital. So it spans some different roles, clinical and medical. We work closely with the oncologists, and we have what's called multidisciplinary conferences. So Steve sometimes will have cases that that he brings to us, and we will discuss them. We have radiologists, pathologists, all of the team, and we discuss each case and determine what is the best care for that patient.
So when the person enters the screening program, they're really at the beginning of a process that could wind up in many different areas, but almost all these different paths can be handled at the Steeplechase Cancer Center?
Yep.
Okay.
Mm-hmm.
So the diagnosis, if they unfortunately have cancer, the treatment, smoking cessation, testing, so the role of the navigator is to sort of help them with each of these decision points.
Basically navigating them through the system.
Is there any other aspect of the Lung Cancer Institute at the Steeplechase Cancer Center that you would mention? I mean, we talked about multidisciplinary treatment.
Yeah, I think that I would like to emphasize that because we have a unique opportunity there where in one place at one time we have the expertise of pulmonologists, of oncologists, of thoracic surgeons, of pathologists, of radiation oncologists. We have the clinical trial coordinators. We have the patient navigator. There's this whole team that reviews individual cases one at a time, and you have an opinion from everyone all at once, which is used to take weeks or months for an individual to go through that process without having a team like that.
So the resources that are all in the same place are the minds that are deciding the care, as well as the fact that the different settings are all in the same place.
Absolutely.
And that accelerates things a lot for patients.
Absolutely.
The, you know, we mentioned it over and over again about smoking. You know, I would imagine some patients with lung cancer were not actually smokers, but the majority of them were smokers, correct?
Correct. I mean, smoking is the major risk factor for developing of lung cancer. Other factors are radon exposure, and New Jersey does have high radon concentration areas. So if your house has not been tested for radon or has not been tested recently, it is advised to do so. And those are simple at-home kits that can be done. Some are just mail-aways. Some you can pick up from a local radon testing site. If you sell your house or if you buy a new house, you know, radon testing is mandatory and it has to be done. For others, it's genetic factors that are involved, and then there's secondary factors, chemical exposures that are hard to quantify, or secondhand smoke exposure, which is hard to quantify. That can be a risk for developing of lung cancer.
With many more places not allowing you to smoke, are we expecting to see fewer cases of lung cancer? I mean, certainly people who still choose to smoke are going to have the same risk as before all the laws changed, but is secondhand smoking reduction, is that, you know, that was the goal of all this rules. Do you think you're going to see that? Do you have any idea, or is it unknown?
I mean, we certainly hope so, and we expect to see some reduction in the new cases of lung cancer. However, quantifying exactly what secondhand smoke exposure is very difficult. If you have for example, if you have a smoker in your household and they smoke a pack a day, what is your exposure? How close are you to them when they are smoking? How big is the house? How good is the air filtration system? All those things need to be taken into account. If you're a bartender working at a restaurant that allowed smoking and most of the patrons smoked, your exposure is higher. If you're at a bar that only a few people smoke, your exposure is less. So secondhand smoke is extremely difficult to quantify, and the prediction for a reduction in cancer deaths or cancer cases is more difficult because of that.
And the people who in the study showed the benefit were the people who themselves were smoking.
Correct.
For 30 or more pack years.
Right. These were active or recent past primary smokers.
So just talk a little bit about that risk factor. You know, we talked about the smoking cessation program. We talked about you know, its role in lung cancer. We've talked in other shows about the role of smoking in pretty much every other condition or cancer. Do you have any you know, opinion about smoking when you encounter patients who smoke?
Well, they should stop.
How do you know, it's easy to say and
right.
difficult to do. You
so
know, what's the way to help people approach this problem in a manageable way?
I think it needs to be individualized. And the fact that we have a quit center at Somerset Medical Center is a great resource. Because they can have individual sessions, they can have group sessions, they can review all the cessation techniques available, as well as the nicotine replacement products that are available. And for some individuals, that's a blessing, and when they haven't been able to quit on their own, they can take advantage of those resources, and that can help them quit. For others, they have to pick a quit date and just go cold turkey, and they'll do it on their own. And for others, they do a stepwise reduction in which they go from 20 cigarettes a day to 18 to 16 to 15, and they keep on going. But they have to be very motivated, and they have to want to quit. And I think that is the first step that a smoker has to take. They have to want to quit. The family yelling at them, their physician telling them they need to quit. It helps, but usually there's that initial resistance there. When somebody comes in the office and they're smoking, and usually I don't tell them, you need to stop smoking, I ask them, do you want to stop smoking? And the individuals who say, I would love to stop smoking, I just can't do it, those are the ones that we can help. The ones who say, I really don't want to stop, I'm not going to be able to convince that person to stop smoking. I will educate them about the benefits of stopping smoking, the risks of continuing smoking, but they have to be ready to stop smoking as the first step.
Now, if somebody's unfortunate enough to get lung cancer, if they didn't participate in a screening, what's a more common way for people to find out that they have lung cancer?
Well, that's one of the things actually I'm currently doing, and when we have the lung screening center up and running, we won't really be doing it as much anymore. But I follow up on all of our incidental findings. A patient's coming in for surgery and has to have a pre-op chest x-ray, and they identify a nodule or a mass. That's often how we will find somebody has something going on before they're symptomatic. Those are all followed up on. We send them a letter or their report, and they'll come in, and we'll bring them in front of the multidisciplinary team and discuss how best to follow up on them. But often that's how it's found. Before it's symptomatic, it's just by accident. So pre-op checks and...
How about patients who are found due to symptoms? What's the common sort of course of discovering it with them?
Yeah, unfortunately, once the patient has developed symptoms and it's related to lung cancer, it's very uncommon to catch them in an early stage. Usually they're a more advanced stage of cancer, and the treatment options become more to control the cancer rather than curative.
What symptoms are we talking about here? I mean, losing weight?
Sure, weight loss can be attributed to cancer, though obviously it could be from many other things. Chest pain, cough, and it doesn't need to be a productive cough. It could be a dry cough, coughing up of blood, shortness of breath, wheezing. I mean, those are the majority of the symptoms that we'll see. There could be secondary symptoms if there's already metastatic disease in another organ. Sometimes we'll have patients present with a seizure because they have metastasized to the brain, and that's the first time that they know that they have lung cancer. They never had any symptoms of shortness of breath or cough or chest discomfort. They just come in with a seizure.
So finding lung cancer early, what you're avoiding is not just the possibility of you becoming sick and becoming ill and dying. It's often a very uncomfortable, unpleasant kind of illness when you find out that you have lung cancer the other way, whether it being short of breath or coughing up blood or having a seizure. I mean, you're describing very dramatic and uncomfortable ways of being ill.
Yeah, there's nothing pleasant about lung cancer. It tends to be a relatively aggressive disease, and that's why these screening trials is such an important finding, because if we can catch these cancers early and treat them early, the success rate for cure is much higher.
Hey, I think that's clear, and certainly I'm going to be encouraging any of my patients who have risk to be looking at possibly being screened. Has there been any improvement or any optimism in the area of cancer treatment for lung cancer patients who find out not through screening, who find out through symptoms? Has there been any, let's say, improvement in life expectancy of a year or 2 years, or is it still very dire prognosis?
The devil's in the details as far as an individual's prognosis. Generalized statistics are helpful for guidance, but when you're sitting with a patient one-on-one, it really matters what exactly is going on with them as far as their prognosis. As far as advances, thoracic surgery used to be a difficult process for patients to undergo. They had to undergo what they called a thoracotomy, where their chest was basically opened up from front to back, and the recovery was quite extensive. Now with the VATS surgery, the video-assisted surgery, the recovery time and the mortality rate from the surgery is markedly reduced. So that's been one advance. And then chemotherapy and radiation therapy has made great advances. There is more targeted radiation therapy available now. There's different types of radiation therapy. And the chemotherapy regimens that are utilized are constantly undergoing evaluations for which is the best for an individual type of cancer and stage of cancer.
So those possible improvements notwithstanding, I think we have a clear message here. Don't smoke if you haven't started smoking already. If you are smoking, do whatever you can to consider stopping. And if you have a considerable smoking history, you have to talk to your physician about whether you're a candidate for this screening, because we might be offering a significant survival advantage to this group of patients. So,
I think
did
that's
I get
good
the
advice.
message?
Yeah, I think that's very good advice.
All right, I want to thank you both for informing us about this new program and smoking and cancer screening in general, and thank you for being at the show.
My pleasure. Thank you.
This concludes today's episode of Somerset Medical Center's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-800-443-4605. For more information about the lung screening program at Somerset Medical Center's Steeplechase Cancer Center, please visit steeplechasecancercenter.com. Thanks for watching.